Good evening from all over the world. Well, it's evening here in Johannesburg, South Africa. I should say good morning and good afternoon as well. We are really very honored to have our next speaker, and it's an honor for me to introduce you as well, Susana. Susana Morales is from the Faculty of Pediatric Dentistry graduate program at the University of Costa Rica in San Jose. And she also has a private practice in Cartago. And what is really great, Susana, when I read your bio, is that you are in private practice, but you are also experienced as a teacher in the pediatric dentistry postgraduate program. Your orientation is to research in medical sciences. Your ability to coordinate scientific activities and teamwork really is amazing. Susana is a well-known national and international speaker, a Master of Education in Information Technology with emphasis on the production of instruction media. Also, Susana has been the president of the Costa Rican Academy of Pediatric Dentistry. She's a directorate postgraduate of the program of Pediatric Dentistry and member of the World Education Committee of Pediatric Dentistry, a member of the Costa Rican Academy of Pediatric Dentistry and the Latin American Pediatric Dentistry, IAPD, and also IAPD. Susana, we are so privileged to have you speak from Costa Rica, and I give over to you. Welcome.
Thank you for your kind presentation. And I am greetings and good morning from Central America. I hope you are healthy and your family too. I am thankful for this opportunity of sharing through technology. Useful as it is, I hope we can share in person soon and enjoy as we did in the past. It's an honor for me to participate in this event, and I want to congratulate the IAPD organizers. I have no actual potential conflict of interest in relation to this presentation. I am from Costa Rica, a small country with beautiful beaches and rainforests, which I invite you to visit. I work at University of Costa Rica, which is a state university, specifically as the postgraduate pediatric dentistry program. In the past, I was a coordinator of the program, and in the past, I was the president of the Costa Rican Academy. Those are my students who are now studying virtually, keeping contact with patients through video call. The objective of this lecture is to understand the process of how hypomineralized enamel formation and its diagnosis and clinical implications. The term molar incisor hypomineralization, MIH, was first introduced in 2001. It was defined as hypomineralization of systemic origin, presented as the marked qualified defects of enamels of 1 to 4 first permanent molars, frequently associated with affected incisors. Before 2001, other terms as hypomineralized permanent first molars, idiopathic enamel hypomineralization, non-fluoride enamel opacities, or cheesy molars has been used in the past to describe this condition. Actually, the term chalky teeth had been introduced as public-friendly by a group of experts from Australia and New Zealand. Did this condition exist in the past? The aim of this paper was to study an archaeological population of teenager thieves from the 17th and 18th century. Skeletal material found in London cemetery for enamel defects included molar, incisor, hypomineralization, MIH. 45 dentitions were evaluated and 557 teeth were photographed with lenses. The results of this investigation showed that 90% of the teeth had hypoplasia or MIH. 28 of the 45 showed moderate or severe injuries. In conclusion, many teeth show hypomineralization or hypoplasia. These pictures show severe structural defects in the enamel. To understand this pathology, it is important to remember the process of enamel formation. Enamel is built up with presence of hydroapatite. There are two factors that control the process: genetic and local. The genetic process determines the size, shape, and color of the tooth. Genes encode RNA through DNA, and most of the RNA encoded is used to make proteins, not minerals. Dental enamel formation is highly specialized, and the most directly involved proteins in enamel biomineralization are specific for it. The amelogenesis occurs in stages like secretory stage and maturation stage. Dentin and enamel formation take place simultaneously. And both processes start along the line that will become the dentino-enamel junction, or DAJ. The final length of the enamel crystal is determined by how long the ameloblasts continue to add proteins. During the secretory stage, ameloblasts are tall columnar cells with a proximally polarized nucleus. After depositing the aprismatic enamel layer, secretory ameloblasts develop a cone-shaped tonus process at secretory distal ends. The enamel crystals do not grow continuously, but rather extend in increments that manifest in cross striation, are known as stria of Retzius. During the maturation stage, enamel crystals grow in width and thickness to replace the loss of organic matrix, causing the enamel layer to harden most of the mineral in the enamel layer, depositing during the maturation stage. The ameloblasts move calcium, phosphate, and bicarbonate. A significant feature of the maturation stage is that the pH of the fluid surrounding the enamel crystals oscillates from less than 6 to 7.2. These pH fluctuations are similar to those that tooth experience naturally, following its eruption into the oral cavity. Look at the changes of the crystal signet when it's erupted. The most abundant protein is the amelogenin. It can be used as a marker for sex determination in forensics because it is present in X and Y chromosome. It forms nanospheres and gives thickness to the crystal. Ameloblastin, enamelin, and tuftelin are other enamel proteins that crystallize during maturation. Enameling is more related to the Q4 chromosome and amelogenesis imperfecta. This video shows what happened.
Masons of the tooth world go to work. The cells of the inner epithelium have elongated into ameloblasts, and the neighboring cells in the dental papilla respond by changing into odontoblasts. Now they move toward the center of the papilla, leaving a thin tube of cytoplasm and a layer of dentin. And now, the ameloblasts start to move, leaving behind the hardest tissue of all, enamel. The resulting rock-hard crown of enamel and dentin is a miraculous feat of cellular engineering, but the engineers haven't finished yet.
The histology shows the amelogenesis begins with the secretion of the matrix. Enamel is the hardest tissue of the body. It's one of 2% organic components and 3 to 5% of water. Classification goes as follows: matrix impregnation by layers, mass impregnation, and then crystallization. Hypomineralization occurs in the first 3 years. Qualitative mineralization and incomplete maturation. It manifests the zone of the state of development. The enamel thickness is normal, but the morphology of the prints are altered. It is an alteration in the reabsorption power of the organic matrix and the inhibition of proteolytic enzymes by retaining proteins that prevent crystal formation. Depending on the defect, the enamel could be white, yellow, or brown color. The enamel is from ectodermal origin. It's secreted by the ameloblast differentiated for external epithelium, enamel. Hypomineralization is given after the deposition of the full thickness of the matrix. The transitional ameloblast is vulnerable. When the cell does not complete its maturation, hypomineralization occurs. During the animal maturation, first, removal of the unstable acid mineral, then replacement with acid-resistant apatite, and finally, incorporation of calcium and phosphate to increase the thickness of the prism. The apatite needs a correct pH, sources of calcium and phosphate to determine correct color, porosity, and distribution of the enamel. The characteristics of hypomineralized enamel are a typical restoration, fracture of the post-eruptive enamel, presence of the marked opacities, and sensitivity. The differential diagnosis have to be done with hypoplasia. That is a failure at secretory stage, has rounded margin, and is not related to caries. Fluorosis, diffuse opacities, number of teeth involved depend on the time of the explosion. And amelogenesis imperfect, involve all the teeth. Family history is present, all may appear tabrodontic on X-ray. Wide spot lesions, caries, located in areas with biofilm. This image shows the difference between hypomineralization and hypoplasia. Pre-erupted enamel in hypomineralization has the thickness of the enamel, but not the quality. When the top erupts, the enamel can break down and easily caries can be related. This image is from the page of the D3 group, which dentists from Australia and New Zealand created for parents and professionals, and I recommend it. What do you think of this picture? For me, this patient has fluorosis, but also molar incisor hypomineralization, and how the left primary canal has opacities. For a correct diagnosis, you have to clean the surfaces, evaluate the incisor in a humid environment, look for limited opacities, white or yellow or brown color if the enamel is ample, porous or soft, and if there are atypical restorations. A good photography will be helpful. Transillumination, the light has to come from the cervical. This effect was done with a green filter. Other authors recommend a polarized filter. The prevalence of these conditions grows from 28% to 40%. It can vary from 1 to 4 molars. In 30% is associated with the incisors. There is a direct relationship between the number of affected teeth and the severity. The number of affected teeth varies from 2.5 to 5.7. The average of prevalence was 15%. This data was retrieved from 121 studies of 47 countries. MIH is classified as mild, moderate, and severe. Mild has bounded opacities, isolated, no dented sensitivity, and there is no association to caries. Moderate has opacity limited caries to 1 or 2 surfaces without involving cusp. Concern about aesthetics in post-eruptive fractures. Severe has enamel fractures, atypical restorations, sensibility, coronary destruction, concern for aesthetics. Some dentists report open bite related with MIH. It can be caused by the tongue protecting the molars to sensitivity when breathing, but it's not scientific evidence of this. This molar is from a 6-year-old boy and it's partially erupted. After the breakdown of the enamel, caries go very fast. This index is more specific. It includes the sensitivity and the defect. For example, this molar is 2C defect, 2/3 of the station near the pool without sensitivity. It helps with the statistical reports. This graphic shows by color the age of the calcification of the tooth. As you see, blue, yellow, and red involve the first molar and incisor until 3 years of age. The systemic diseases before age of 3 related with hypomineralization are upper respiratory diseases, asthma, rubella, chickenpox, antibiotics, epilepsy, nutritional deficiencies, dementia, and palatal cleft. Perinatal conditions associated: premature birth, respiratory difficulties, hyperbilirubinemia, hematological disorder, hypocalcemia, intracranial hemorrhage, metabolic disorder. It is necessary a regular pH during mineralization. This determines the rough or smooth surface of the prints. Cyst fibrosics, for example, affect the pH. Calcium and phosphate have to be in the appropriate levels to increase the carbon in the phase of discharge of mineralization. Enamel proteins bind to calcium through phosphoproteins controlled by vitamin D. Hypocalcemia also predisposes to molar incisor hypomineralization. When breastfeeding time is dragged on for more than 3 years, there are studies which associate this with molar incisor hypomineralization because of the release of dibenzopidioxine polychlorinated PCBPS.
Susana,
Yes?
I'm sorry to interrupt. We are getting quite a few people that that are saying the volume is very low. I'm not sure if you can move your headphone speaker closer to your mouth, perhaps, if that will help. Let's try that and then continue. Thank you so much.
Can you hear better? Can you hear?
Yes.
There? It's better?
Yes, I think it is. Yes. Thank you so much. Perfect. Thank you, Susana.
Sorry.
No problem.
Okay. When breastfeeding is dragged one or more than 3 years, there are studies which associate this with molar incisor hypomineralization because of the release of dibenzopidioxine polychlorinated PCBPS, plastic consumed by the mother, which are pollutants in the environment, fat-soluble, part of the nutritional chain. These effects are mediated by the aryl hydrocarbon receptor necessary for crystallization. This new study found protein as human serum albumin from blood in Marietjie molars, which is a huge discovery. This image shows the stage of calcification in primary teeth. When enamel defects occur in primary teeth, more frequently in preterm groups, permanent teeth have MIH and caries. Preventive management is super relevant in these cases. Early detection is very important. Kids with this condition need to visit the dentist more frequently, and the treatment can be uncomfortable. Identify the risk. Medical record should be linked to the etiology. Susceptibility to caries and erosion, diet recommendation, toothbrushing, and mineralization are very important. Determine the complaint to plan the treatment if it is pain, sensitivity, or aesthetics. It is important to create an environment with calcium and phosphate, the missing minerals. Recaldent products have to be recommended, such as my paste or enamelon for home use. chewing gum, and varnish with fluoride, with the idea to oversaturate, creating a deposit of calcium and phosphate ions on the enamel surface, reducing sensitivity and improving the hardness of the enamel. This strategy includes brushing with a soft toothbrush and fluoride paste. Use paste with CPP ACP applied over the teeth surface and seal the enamel as soon as possible. Electric, sonic, or water pick are not recommended because of the fragility of the enamel. Let's talk about the treatment. Clinical problems vary. Sometimes, in severe cases, the first permanent molars can be extracted, and second molars take their space. This condition has to be consulted with an orthodontic. In these cases, it's important to confirm the presence of the third molar. The choice of materials depends on the defect of severity. They are created to join perfect enamel, not hypomineralize. It is necessary to pay attention to sensitivity, improving the comfort during the appointment. If not, behavior problems may occur. Sedation will be necessary. We can face difficulty obtaining adequate analgesia, and caries development could be very fast. Therefore, limiting the lesion could be useful. If anesthesia isn't accomplished with chronic inflammation using conventional techniques, it can be complemented with ertecaine. Also, intraosseous or intraligament technique, but sedation could be considered. The purpose of this study was to determine pulpal status of hypomineralized permanent molars. When comparing the pulp of extracted first permanent molars, the inversion density was significantly greater in pulp horn and subarachnoblasthic regions of the hypomineralized teeth than in sound teeth. Immune cells were more abundant within pulps of hypomineralized teeth exhibiting enamel loss. Vascularity was found to be similar in both hypomineralized and sound teeth, but was significantly greater in hypersensitive hypomineralized samples. In conclusion, this study provides biological evidence that inflammatory changes may be present within the pulpal tissue of these teeth. Dentists frequently face difficulties in defining the cavity margins. Cavity designs plays a critical role as defective enamel remnants compromise the results. Glass renomer cements or resin-modified restorations can be considered only as an intermediate approach until definitive restoration is placed. Resin infiltration, known as erosion infiltration with a low viscosity resin, is capable of penetrating demineralized enamel. Resin composite is the material of choice. Amalgam should be avoided. Preformed metal crowns can be used successfully in severely damaged MIH. Only failure has been reported in enamel defects. Retreatment the enamel with 5.25% of sodium hypochlorite can improve the bone strength. There is an significant statistical difference between the use of self-aging adhesive or fifth generation, which I prefer. Reformator crowns can prevent further post-eruptive enamel breakdown, manage sensitivity, establish correct interproximal and occlusal contact with easy, low-cost technique, and can be done in a single visit. Inappropriate adaptation can produce an open bag and gingivitis. Last year, zirconia crowns has this option for permanent molars. As you can see, this patient has different lesions. Maybe each one will need a different treatment. One with abrasion, other with resin, some will improve with whitening. It's important to analyze the alternatives. I recommend this international group on Facebook, where many experts share their cases and knowledge. This page is also very useful. I recommend it for parents and professionals. This case is from the web page. Look at the right central incisor and the lowers. This case was restored with amalgams, and look the breakdown of the margins. This is a before and after of restoration with resins and crown from the same page. This is an 8-year-old boy who came to a control visit. I always use disclosure agent. The abundant biofilm is very difficult to remove because of the rough surface. He brushes us with a soft brush during the appointment, and I can see how effective his technique is. When this case came into my office, the patient had an amalgam. I took an X-ray and confirmed a good adjustment, and I decided to keep it. The right upper molar was sealed, the left one restored with dressing, and the lower one with a stainless steel crown. Because of the damage, as you can see, the 4 molar has very different grades of severity. To clean the surfaces of severe cases, you can use glycine air polishing system. Let's see some clinical challenges. Some pictures were facilitated by students or colleagues with didactic proposals. First things to do is to think if we are going to keep the tooth. This molar have a deep lesion. In this case, I recommended partial removing of the infected dentin, clean with chlorhexidine, 0.12%, and the use of biodentive or a glass ionomer. Take an X-ray, and 6 or months later, decide if more dentin have to be removed and then restored. In this case, a crown is an option. Look at this permanent canine. It is the only enamel defect in this patient. This lower incisor gave us the alert for molars. They have to be checked as soon as possible. This severe case includes 4 or 5 incisors and the 4 molars with MIH, but the primary upper second molar were extracted. Probably they have shown this condition. This hypomineralization in second primary molar is related to severity in permanent molars. And see the enamel breakdown due to failure related with the use of amalgam in cases like this. What you should do? First, a selective removal of dentin. Then, Clean with chlorhexidine and use bioactive materials like biodentin and weight. Open apex and pain is a bad prognosis. In these cases, the option of extraction should be considered. If you have to keep it and the pulp exposes and is vital, the bleeding must be kept under control. A partial pulpotomy or conventional pulpotomy should be done. A study considered what to do. Resin infiltration? This is an option, but it's difficult to predict a result. In this case, I will do resins. Extraction? It is a difficult decision, but it has to be considered. Look at the upper molars. Well, as you can see in this picture, it is a deep lesion, and in the X-ray, there isn't enough space for canines. Can the first molar be extracted? We are not sure that the 10 molars are there, and we can make that decision without being sure. We are going to restore with biomaterials and weight. This X-ray from a 7-year-old girl shows 4 affected molars and were restored with amalgam. There isn't enough space for the premolars. The left permanent molar is impacted, and the second right premolar isn't there. The orthodonts recommend to take out the second temporal molars, but to promote the position of the first permanent molar, cut the distal surface of the second temporal molars to correct the angle. They then change the amalgam for composites. After the position of the first permanent molars improved, I will extract the second temporary molars. The left primary molars show a deep caries lesion. Look at the right first permanent molar. What would you do? I did a stainless steel crown. This is an 8-year-old boy with 6 affected incisors. The 4 molars were severely damaged and were restored with crowns. I studied composite for anteriors, and this is the before and after of this case. It is important to find out why the prevalence of this pathology is rising, as well as understanding the molecular process and its clinical implications, improving the early detection and implemented a preventive and restorative treatment early. These are my social media. And thank you very much for your time and interest. And sorry for the technical problems.
Thank you, Susana. It was really a very, very interesting topic, and I would like us to go over to the question and answer sessions now. There was some very valuable information there. There are questions that I'm going to put to you, and if you can answer, please. You can also see them on the WOBA app. So please tell me if you're not clear on the question. The first question is, why do patients with MIH experience sensitivity, and how do you manage that condition?
Yes, well, the sensitivity is because we don't have degradation of the enamel. And the pH in the oral mouth is irritating the pulp, and it is a chronic inflammation. And what we should do to help these patients is to use product with calcium and phosphate. And they can use, you know, the retainer with these products at night, and they can put in the tooth. But if they need to restore the tooth, if there is if we don't have enamel, we need a crown. If we have partial cavities, we need to restore with resins or materials to reduce the sensitivity.
Thank you. That makes great sense. The next question, please elaborate on how to assess MIH radiologically. So on X-rays, how would you assess MIH on an X-ray?
Well, it's difficult because sometimes, you know, the thickness of the enamel is correct. The quality of the enamel is not correct. Maybe the X-ray, if the density of the enamel is correct, we are not going to see it. But the problem is when this tooth comes to the oral cavity, and the very fast caries goes in this enamel, and you can see it in an X-ray. But now transillumination is very helpful because you can see and limit the damage of these enamel lesions.
Thank you. So yes, I think X-rays are still quite valuable, even though we always need to assess it when the patient's in the chair clinically. This is a really good question, is how to improve the adhesion of restorative materials in MIH cases. I know you've shown us some techniques. Do you have any answer for us on that one, Susana?
I think it's very important to use always rubber dam, not only to protect the other tooth for the sensitivity, and to have a good environment for bonding. And you can use in the enamel the 5.25% hydrochloride to clean the proteins that remain in that enamel, because that proteins there don't allow the bonding.
Thank you. That's very valuable. What is the prevalence of MIH in Costa Rica? What do you find it to be?
Well, we don't have a study now, but I can say every week I have a patient with MIH, and sometimes very severe cases. I heard yes. I have the information from this page in Australia. They say one child every 6 has this condition.
Yes, I can say from the same point from South Africa that I do see at least one patient a week, and it's becoming more and more. Good. The next question has to do with fissure sealant. What material do you use for fissure sealant in teeth with MIH, and what is the retention rate of these sealants?
Well, I use sometimes glass ionomer as a sealant when the tooth erupt, because to prevent the breakdown. And when we can isolate the tooth, I recommend a sealant with a composite sealant. Yes, and sometimes if the enamel is not with the hardness, it's going to break, and then that's why we need to delimit the lesion to restore with resin. If don't, we're trying, but sometimes we cannot predict what is going to happen in these cases.
What protocol or material do you use for microabrasion? Do you use an infiltration material, or what do you use?
Well, and I have used yes, the Icon products, but it's very expensive in our country and difficult to find, and we cannot predict what is going to happen. And I think it works with white spot lesions, but
yes.
And at the university, we tried with abrasives, and in sometimes we have failures, and sometimes it goes well, but we cannot predict in these cases what is going to work. That's what is difficult to recommend in the private practice.
Yes, now I think we all practitioners realize that it's not easy to to deal with this. This is a very interesting question, Susana. Will calcium supplements be of any help?
Yes, well, I use my paste or enamel, and
I mean a supplement like a tablet that you take.
No, I don't use tablet. I don't have tablets with calcium here. No, only chewing gums with recaldent.
So taking of any like a vitamin supplement with calcium in will not be of. There's no research.
And there's no studies that recommend that.
Thank you. What is your opinion about root canal treatment on a severe MIH tooth?
It's difficult to know what is going to happen. I think we need to avoid the apexification because of the prognosis. It's better if the tooth is vital to try to do a partial pulpotomy or a pulpotomy. But sometimes if we have to look for the apex too close, we have to be patient and wait to see it's happened. In these cases, if we have problems with the space, it's better to extract the tooth and try to, with orthodontic treatment, to don't sacrifice a good premolar.
Yes, because I think that is what you also explained with the age, the correct age to see if it's the correct age to remove a molar or not.
Yes.
So the age would also be important.
Yes, it's important to see if the third molar is there to decide that. We can do it early, but we have to be sure.
Okay, so the age, it will only be after 10 or 12 that you will really be able to see. So would you say you would try and keep the tooth then until that age?
Well, sometimes I can see it earlier. I have patients that I decided at 10, but yeah, sometimes we have to wait until 12.
Okay. A question about what are newer diagnostic methods for the detecting of MIH? Are there any new diagnostic methods?
Well, I think the system with transillumination or polarized are very helpful, and the equipment that measure the density of the enamel and can be useful.
Thank you so much. The next question, sorry about my video. Okay, it's asking how early can MIH be detected?
Well, we can predict that the problem could be there if we see in the second temporal molars this hypomineralization. The position is near the cervical third, and there is related with the mineralization of the cusps of the first permanent molars.
Thank you. A question, why, if MIH existed in the past, it wasn't reported until recent times? That's very interesting, because we all saw it coming, but it's so, it's much more, we see much more of it now. That's an interesting question.
Well, maybe the prevalence is rising, but I think in the past we have in Latin America we have more caries, and maybe we saw the problem with where it's a severe cavity, and we say it's a cavity. We don't think in the enamel. Now we have less and you know, less lesions, and maybe we see more the defect. We have now programs with fluoride, and maybe in the past we don't. And in the past here in Costa Rica, we have more cavities for the fluoride water salt program. But we are not sure, but I think maybe in their environment is raising this condition, maybe.
Definitely. So it's asked the doctor, any use of CBCT diagnosing in MIH in the pre-eruptive stage? Will that be, is that familiar? Will that help as a screening tool? That's the first question from that doctor.
I'm not sure what is that, the letter that you said.
The CBCT scanner, that type of X-ray, the 3D scan X-ray, before the tooth erupts, will that be, do you use that as a screening tool?
Well, I am not familiar with that.
Okay, so they also want to ask what we can do to increase mineralization before the tooth erupts or even get diagnosed. So if
I think if we have an environment in the mouth with calcium, phosphate, and fluoride, we can improve the maturation of this enamel.
Okay, so that would definitely improve it. So do you perform tooth preparation before you use the preformed metal crowns?
Yes, I prepare the tooth. I don't use the whole technique. I'm not familiar with that.
Again, a question about infant formula supplements. If a primary second molar are having hypoplasia, can we not prevent the 6-year molar hypoplasia by infant formula supplements?
I'm not sure. Ask me again the question, please.
Okay, so it has to do with again a supplement. If the primary second molar, if you can see the tooth has hypoplasia when the child is 3 or 4 years old, can you prevent that the 6-year molar is better by infant formula supplements or any other supplement?
No, because this hypomineralization goes before 3 years old, the problem, and we cannot improve that after that. No.
Thank you. What is the relationship between the time of breastfeeding and the occurrence of MIH? Is there any relationship?
Yes, the breastfeeding is because these toxins in the products that the mother incorporates and can go through the milk And when the breastfeeding prolonged for more than 3 years, there is a relation between this problem. It's not the milk, it's the toxins in the diet of the mother.
What type of toxins would that be? Is it?
Is the DPCD is let me is the dibenzopidioxins polychlorinated PCDDS.
Okay, that is very interesting. We have a question about Icon, but you said that you are using Icon as well. What is your opinion for zirconia in permanent molars? We know that we need to remove a lot of tooth structure to put a proper crown.
Yes, as for aesthetic reasons, if the parents of the kid want that, but I prefer a stainless steel crown because it's more conservative, and then when they finish to grow, they can change for another material.
Okay.
And I think the adapt for a metal crown is easier, unless for me. I use a photography because I don't have cases with the first permanent molar with this kind of molar, but it's an option if the parent wanted, I think.
Yeah, yes, I think I agree. So this is also a question I'm interested to ask, and that is about the local anesthetic you use, because often, as we all know, the teeth are more sensitive. So how do you anesthetize the teeth that are that sensitive?
Well, I use the same technique as with other patients, but I complement with articaine infiltration.
Okay. Okay. So do you do that buccally even in the lower jaw?
But for the block, I use lidocaine and infiltrate the articaine. Yes.
As well. Okay. And do you find that if you give before you do the treatment a week or two before, and you give them tooth mousse and fluoride in those trays for sensitivity, does it make it less sensitive if you use the local anesthetic then?
Yes, it'll improve.
Okay. Can fluoride varnish help in early remineralization of mild lesions?
Yes, it's recommended. There are many studies that said it can help too.
They're asking, I'm going to allow a few more minutes for questions, if that's okay with you, Susana, because we have some extra time. Thank you, we appreciate that. According to your mind, what is the reason, or according to you, what is the reason of the high prevalence of MIH in your country?
Well, I'm not sure, but maybe we are not having, we are changing something could be in our diet or in our habits, and something is changing because it's very frequently. And it's interesting for me that the severe of this damage is not symmetrical because other enamel defects are the same in the right and the left. And this new study that find albumin proteins in blood proteins in the enamel can give us a hint of it's something different, this problem, because we thought that the proteins that are in the enamel are the protein of the enamel, but now I know are blood proteins. And maybe something is you know, in the premature kids or something is going different than in the past, but we are not sure what is it.
What's causing?
Yes. Yesterday I have a patient, and the three brothers has this problem, And I was talking with the mother about this presentation, and I tried to ask more questions because we don't know what the 3 kids has this problem. And she told me, well, the problem I had was I have a low blood pressure, and that's interesting because he has to receive medical attention in the when she was pregnant for the 3 kids for this.
Yeah, I think there's a question that follows up on this, which is asking about the cause of MIH. The person is asking, are there more chemicals or toxins beside the ones that comes through the mother's breast milk? I've heard about toxin in food due to agriculture and to environmental pollution, preservatives,
Yes.
and that stuff. Is that also?
Yes, yes, yes. It could be we are not eating food. We are eating, you know, products that are created for nutrition, but they're not naturally, and maybe it can interfere with the enamel. Could be that too.
Not sure yet.
Not sure. We don't know.
Any use of SDF, or have you used SDF, and have you got any results
what
with
is that?
The SDF,
what?
silver diamine fluoride.
Oh, okay, okay. We don't have that in Costa Rica, but once I have it, and I haven't used in this case. It could be useful, but you know, the aesthetic could be worse. If the aesthetic is the problem with this product, maybe it doesn't work. And if we have deep lesions, we cannot use it. But I think when it's in the temporal second molar, could be an option because it's in cervical, this lesion.
It's far back, yes, yes. Did you try the use of deep fluoridation to decrease the hypersensitivity? I'm not sure what deep fluoridation means. Would that mean?
Me either.
Maybe it means the tray that you sleep with, maybe using it more often. Okay. I'm not sure.
Okay.
That's what I think.
Well, this deep fluoridation I haven't used, but what I have recommended in several cases is use the retainers with recaldent products.
When you use the retainer, do you put fluoride in and the calcium, like the tooth mousse, or do you put only the tooth mousse?
Well, I think that tooth mousse is better, but we don't have it here.
Oh, I see.
I have used it, but I think it's better that.
Because someone is asking any experience on the role of CPP, ACP in remineralization of milder varieties. So
yes,
we can't answer that one. Someone is asking using of Napo's deep fluoridation method. So we're not sure about the deep fluoridation method. Okay.
No.
Then why do patients with MIH experience sensitivity, and how to manage that condition?
Well, we think what the enamel does to us is protect the pulp. If we don't have a good enamel, we are going to have acids and the hot products in the mouth, and they're constantly irritation the pulp. As I show in the pictures, the innervation in the pulp has a chronic inflammation, and that's why they have sensitivity. And yes, we need to treat this problem with these products, and also with treatments and early treatments.
Yes, as early as possible. Someone is asking, please discuss the differential diagnosis for MIH. Is that what you explained in the beginning, or can you elaborate a bit more on the differential diagnosis?
The differential diagnosis, the MIH with, I think with, I don't know, with hypoplasia, because I was looking for the picture, but is the difference between the hypoplasia and MIH is the stage of the problem, because the hypomineralization is a problem in the maturation stage. We have the thickness of the enamel, but the enamel doesn't have the quality. But in hypomineralization, we have a problem in the secretory stage. We don't have the thickness, but we have the quality. And that's why it's not, hypoplasia is related to caries, because the enamel can protect, the thin enamel can protect. I don't know if that.
Yes, it's because someone asked a question about hypomineralization, saying it's a developmental defect and not a demineralization. So they're asking, how can the enamel then remineralize?
Well, it's difficult to remineralize. It's like give the ions that help to protect, but it's not that we can, reproduce what the amyloblasts have to be done, because we cannot do that. It's only to give minerals to this tissue to harden, but it's not to build the crystal that it could be. It is impossible.
I am going to close our lecture there. We've had a lovely time of answering and questions and answers. And Susana is more than willing to answer afterwards if you put your questions on the session Q&A box in the WOVA app. We would really like to thank you for sharing your very valuable knowledge, and we all enjoyed it. I found it very, very interesting and very relevant to what I find in my practice on a daily basis. And we were so privileged to have you. We would like to thank you on behalf of IAPD and on everyone that listened in and that looked in. And sometimes, the technology is not all with us, but I think the message came over very clearly. Is there anything you would like to end off, Susana?
Well, I want to thank. I am very honored, and I'm going to ask all the questions that you have, if you have more, and I'm very welcome. Thank you. And sorry for the technical problems. It's very difficult for me to know that we have the problems too, because I was, presenting and.
No, I think it's such an honor to have had you. And I must say, with the IAPD, with the technical issues, we've actually not had many issues. So, and sometimes some people can hear in the world and others can't. So that is why the recording is there. So everyone can, if they didn't hear properly, they can definitely, go onto the recording and they can ask the questions as well. I would like to thank everyone that listened in, and we'll see you. Well, in my time, it will be tomorrow morning, but maybe with you, it will be a different time. And thank you, Susana. We really appreciate it.
Well, welcome.
Goodbye, everybody.
Bye.
Thank you. Bye-bye.
Bye-bye.